Hi everybody, Chapter 15, another review. Chapter 15 on this exam, questions 33 through 60, so we're almost through 2/3 of the test here. I'll be covered drugs affecting the CNS. So here are a list of all the drugs that affect the CNS, which I'm sure everybody knows. Anorexins, anticonvulsants, antidepressants, antipsychotics, dopaminergics, all of these things, mood stabilizers. You'll be prescribing a lot of those. Some of those now will force you to refer your patients out of primary care and into the psychiatrist's office actually, or the neurologist's office. Central nervous system, this is just a review of everything that's included in the central nervous system. Just review that. There's not really any anatomy questions on there, or not a whole lot of physiology actually either. So here we have a list of our diet drugs. This is a big one. We have those phentermine clinics popping up all over the place. You pretty much take your $75. I don't know if these things are legal or not. They take your blood pressure, they give you a B12 shot, and they hand you out 30 days worth of phentermine. Phentermine, I guess, does work for some people, but I think it's probably one of the more abused things going on. I have somebody who comes into my office who's about 6'4", 200 pounds, and when you look why he's there every month, it says obesity. He clearly is not. That BMI is not obese. He's a very tall man, 200 pounds. And when you question him about it, he tells you that he's taking it just for energy. So pretty much now, I've been there a while, and the last time he came in, I refused to fill his phentermine because he's been on it for 3 years, and that pretty much, it's not for weight loss, especially that. He's weighed the same, nor does he need to lose weight. He was weighed the same the entire time. Everybody would love to have that stable of weight. And he clearly states that he takes it for energy. So that's an abuse of the drug and actually off-label, right? So it's to suppress your appetite, not to use for energy. So therefore he's abusing it, and yes, he was mad. Insurance companies are now not paying for it either anymore. That was the word on the street just most recently. So I'm sure that that will cut down on the phentermine use. They all have potentials to cause serious side effects. They should not. These drugs are really only approved for BMIs over 30, and for sure over 20, between 27 and 30, or over 27 if they have risk factors. I don't even think they're going to be approved, period, anymore, because I think they're causing more trouble than they're worth. Okay, so here's the deal with something like phentermine. It should be used short term for weight loss only. It's an amphetamine, so you have to write a prescription for this. You can't just call this one in. So the biggest thing is, you have somebody who's on this and they want to try a trial. I actually had someone today come in and wanted a trial, and that was fine. She wanted to do it for all the right reasons. Her BMI was over 30. I don't have a problem with giving him a trial. I give him my spiel on how I'm not quite so sure that it works unless you've really got a good weight loss plan with it. And then, I also told her that it could cause tolerance, and it should only be prescribed for 6 months. And actually, that's what you need to know too for boards and for your test. It's only to be used short term, and it can cause tolerance. So no more than 6 months. That's really what you want to use phentermine for. Obviously, I don't know that this man that's been on it for 3 years is actually, I won't say dependent on it, but he sure was pretty angry when I said no. And actually, the physician that I work with kind of rolled her eyes at me as well. But I don't really care. I mean, you can't sit there and tell me that you want it for energy. I can't do it. So here you see all your adverse side effect: overstimulation, agitation, confusion, all these other things. Dry mouth, nausea, vomiting. So, and my friend may have withdrawal symptoms, as it says here, so we'll have to see what he does. But it's just not the right thing. So before prescribing phentermine, also you need to take a really careful history and look at all their meds. Make sure they're not doing any SSRIs or St. John warts, because this is something that phentermine will increase serotonin syndrome. So you always want to look at everybody's meds anyway. Okay. So what if your patient was on Adderall already and then they came in for phentermine? I mean, things like that do happen. I mean, I can't even believe these clinics where you can walk in with your $75, because I'm sure a lot of that's going on. Let's see. There was a time, an off-label use of an SRII called Phenpro, not the same as the other one that caused all the heart damage, but this was Prozac and phentermine at one point, and it was kind of an off-label type thing too, but people were using the combo drug. And that's it pretty much with your phentermines. It talks about that, I think, because it is so common. Then we're going to move to your anticonvulsants. You see a lot of these more in kids, used for seizures than anything. Okay, just a little patho up there. So your anticonvulsants. Here's your different types. Dilantin, phenobarb, and Keppra are your three major ones now. Whenever you have a child that has a history of epilepsy, I don't know how many people will do peds, but they need. They also need a home prescription of rectal diazepam called Diastat, in case they go into status epilepticus. That is pretty much standard of care in a peds office. I had no idea until I did my peds rotation. That is standard of care. Okay, so your first line. Let's see. Hang on, I want to go back to this one actually. Okay. These are your first line. I would like a drug though here. Here we go. Okay, so your first line of defense is your hydantoins, and that's Phenatin actually. The biggest thing you need to know about these, you need to know what they do, of course, with your sodium ions. But your biggest thing is you need to know where they metabolize. So in the liver, they have that strong CYP2C9 effect. So these levels will increase with like samanthodine, diazepam, acute alcohol, valproic acid, alpurinol. They decrease effects with barbiturates, antacids, calcium, and chronic alcohol use. So that's what happens. It decreases the effects of the drugs. So you can have people that are, might have a teenager on Phenatin who starts to drink heavily, and then all of a sudden they're having seizure activity. So you just need to know different things like that in case you have some clinical picture that shows up in your office and you're not really quite sure why. So these drugs have many adverse effects: nystagmus, dizziness, itchiness, paresthesia, headache, sleepiness, ataxia. Look at all of them. Cardiovascular effects, urinary retention, discoloration. So they have a whole array of big problems. So let's see if I can throw a question at you that might make you think. Okay, so you're going to give somebody phenytoin for seizures. How are you going to monitor them? You're going to monitor them for hypersensitivity. So you're going to start the dose, and you're going to watch for 3 to 8 weeks after you're starting the dose, because this can lead to hepatitis. So you're always going to watch for that hypersensitivity, and if it's going to happen, it happens in the first 3 to 8 weeks usually. Okay. Okay. Just a little bit more. Just going to have to watch everything they take. Can't drive either if you've had a seizure within a year. Okay. Tegretol, carbazepine. Tegretol used to be really, really popular. I don't know how popular it is anymore. It has a black box warning. It can also cause the Stevens-Johnson syndrome and the toxic epidermal necrolysis. It can induce its own metabolism, decreasing level, which is kind of crazy. So you have somebody who starts on Tegretol, and they come and see you, and they want to know what their level is and if it's in the therapeutic range. And they were in therapeutic range before, and now all of a sudden they were low. So what can be going on? So you're trying to think, well, you're going to have to go back to what I said before that was so crazy. It causes that auto metabolism. It can decrease its own level, even with good compliance. So therefore, it doesn't make it a great drug, which is probably why we now go to things like valproic acid. Depakote's really a popular drug, not only for a mood stabilizer, but also for seizure activity. All right, let's see. Okay, so we'd already said it auto-induces metabolism, so your therapeutic level might decrease, and you also have to worry about your bone marrow depression, so you have to monitor the CBC every 3 to 4 months while taking Tegretol. Holy cow, I sure did miss some words there. So we want to check a CBC every 3 to 4 months while they're on Tegretol. And you also want to remember about the Stevens-Johnson toxic skin issues. And you also want to worry about the bone marrow, all blood dicrases, which is uncommon, by the way, but they throw it out there. Okay, let's see. Okay. This is another one that's used in kids, Serotin, more often than adults. Suppresses the seizures. It's absorbed in the GI tract, doesn't seem too bad. Once again, causes all kinds of problems with the blood, agranulocytosis, aplastic anemia. So it's all different types of issues with the blood. That's the most common thing that you're going to worry about with this drug as well. Lamictal. Lamictal, too, once again, is also used for bipolar, similar to what Depakote's used for, but it's used for, it's an anti-seizure drug as well. And I'm just trying to find that all you really too much need to know about this is the level can be decreased by birth control pills, estrogens, and barbiturates. I'm trying to see what else. Lamictal's been around a long time too. You can use this with Phenatin, you can use this with Depakote, you can use it with a lot of things. Let's see, we're not to Keppra yet. Okay, so if you have somebody who's taking Lamictal and all of a sudden they come to your clinic and they've got a fever and they've got swollen lymph nodes, what do you think you're going to do? I mean, are you going to treat them for a strep throat? Are you going to treat them for some viral syndrome? Or are you going to rule out hypersensitivity reaction? The hypersensitivity reaction that comes with Lamictal can actually turn into end organ damage. So what you're going to do is anytime you have anybody on a drug like Lamictal, you're going to think, my goodness. So if they present with fever or illness, they need to be assessed for the hypersensitivity reaction before treating. You're going to see some of these other symptoms. You're going to see also the GI, nausea and vomiting, things like that. But you're going to see severe reactions if they're having that hypersensitivity reaction. So once again, you always have to assess for that. Okay. Gabapentin. We know we use gabapentin for a lot of things. I think gabapentin certainly is a seizure drug, but how many of us have actually used it or prescribed it for seizures anymore. It seems like it's used mostly, at least in my world anyway, it's used for diabetic neuropathy and any type of nerve pain. I've actually even given it to somebody who's had episodes of shingles, and it's kind of worked well. So that's another drug that you just have to be careful with. You want to monitor closely when it's used for seizures for the frequency, duration, and severity, because I'm not so sure that it always keeps them under good control. So if somebody has it to treat neuropathy and they're starting to feel depressed or strange thoughts, what do you think you would do? I guess you probably would need to work them up for a suicidal ideation, I would imagine, and you might want to think about changing their drug. Gabapentin is another drug too that whether it's used for seizures or whether it's used for neuropathy, you start slow and build up. You start like at 100 milligrams TID, and then you can raise it up. Let's see. And topramate, where did it go? Oh, there it is. Topramate, these are the side effects of this drug as well. Once again, this can be used for migraine headaches as well as seizure activity. So the side effects are anorexia and weight loss. This is a normal side effect. And the patients need to monitor their temperature and their ability to sweat. This is another issue with this drug. So they need to monitor their weight often. And so gabapentin, you're going to make sure that their levels, you can monitor drug levels every 3 to 4 months. You can make sure they're not having any derm reactions or anything like that. Does that sound right? No. Gabapentin, you just have to monitor them closely for their seizures. That's it. You don't worry about derm reactions or anything like that with gabapentin. Gabapentin is pretty benign and safe. So let's go back. Hypersensitivity, we're going to worry about Lamictal, and we are going to worry about, let's go back to your Tegratols. We're going to worry about that. And your phenotins, hypersensitivity and phenetin and Lamictal. Okay, Tegretol, we're going to worry about it metabolizing itself and causing seizures, and that's the one where you're worrying about Stevens-Johnson. Okay, and then gabapentin, we're only worried about one thing, monitoring if the patient's going to have seizures, the frequency, the duration, and the severity. No real terrible side effects with that. And topramate, we're going to make sure that we're going to monitor their temperature, and we're going to make sure that they can sweat, especially if you have kids that are outside in heat playing sports. Okay, we're going to go to Keppra now. Keppra was an adjunct therapy. Now it seems to be more of the drug of choice. You never want to stop Keppra abruptly, because you'll be at risk for withdrawal seizures. Okay. The great thing about Keppra, it has very, very, very few drug interactions, if any. It's kind of surprising. There's like no known drug interactions with Keppra. That makes it pretty nice. Let's see. And we already talked about Lamictal. Lamictal, remember, you have to worry about that hypersensitivity reaction. And let's see. And if the level is low, you may actually end up having to, with the Lamictal, you may actually have to, it might be required that you double the dose. That's the other thing. Hang on here. I don't know if it says that either. No, it doesn't. That's the thing. It's really hard to keep a decent level of Lamictal when you're using it for seizures. So once again, patients kind of go through this, metabolize this drug pretty quickly. Okay. That's one thing I didn't tell you about Lamictal also. If you have a patient who's on Lamictal and they all of a sudden want to go on birth control pills, the birth control pills cause the Lamictal to just be metabolized super quick, and then the levels are possibly going to drop, and then you can have some seizure activity. So you may want to, that's another case too where you may end up doubling the dose with the Lamictal when they're on birth control pills. Okay, so we talked about Keppra. And we can go to our antidepressants. SSRIs seem to be the most common, although you will sometimes still see your tricyclic antidepressants. MAOs, I mean, that's no, I don't know anybody who prescribes MAOs. I'm sure maybe some psychiatrist does here or there, but they're just not used. So you have your non-selective norepinephrines, serotonin reuptake inhibitors, and that's your tricyclics, your amitriptylines, nortriptylines, all of these other drugs. A lot of those are used for other things like migraine headaches, actually. So that if you do see them, that's usually what the patient's taking them for. So if the patients present with complaints of depression, take a history of medications they are taking, they always ask about suicidal ideation no matter what. That's the first question. If you have somebody that comes in, it's just for a med refill, and it's just for their fluoxetine or their sertraline, make sure that you always, in the EMR, you're marking that they have no thoughts of hurting themselves or others. I mean, otherwise you are really at risk. And it's not a correct exam. If that's the refill they're there for, you should be asking them those questions, besides just is the antidepressant working. All these two, you want to be careful prescribing tricyclic antidepressants to patients with heart disease. Hang on, sorry. Because they can cause orthostatic hypotension as well. They have anticholinergic effects. But also they are norepi. Let's go back. They are a norepi, non-selective norepi serotonin reuptake inhibitor. Anything with norepi also has cardiac component as well. So always cautious in patients with cardiac issues. There seems to always be questions about MAOIs, and like I said, I don't know anybody who really prescribes MAOIs anymore. So let me go back because I'm sure there's MAOIs, okay, phenozine. There is a problem with phenozine and other MAOIs, okay? So if you're managing in a primary care setting, what do you need to know about the MAOIs? Do we need to know, we should not prescribe others, we should not prescribe Amitrex with that. That's one thing we need to know. Do not give Amitrex for headaches with an MAOI. They can interact with food. This is a big one. It's like yogurt, sour cream, and soy sauce. Those are things that we definitely can't be giving with an MAOI. And they also may have a hypertensive crisis. So what's a hypertensive crisis? It's headache, tachycardia, sweating, and they all require immediate treatment. So anytime you have an MAOI, you need to know that you could have all these adverse drug reactions. And once again, nobody likes to give those, and that would be why. So here's a big slide on this. Okay, drugs. These are drugs that inhibit MAOI, the enzyme that terminates the actions of neurotransmitters such as dopamine, norepi, and serotonin. Must need to know that. Have a low safety margin. Not a first-line drug. Once again, I doubt you'll see it. Many drug-to-drug, food-to-drug interactions can cause orthostatic hypotension. insomnia, diarrhea, hypertensive crisis when used with other antidepressants, foods with tyramine. Never prescribe any serotonin drugs with these. Okay. And this is how they work. They're one of those P450-2D6 substrates, which makes everything increase, right? A substrate. You have inhibitors and substrates, remember that? Tyramine foods can't break down with those either. Okay, so now we have your SSRIs. What if you had a kiddo that was prescribed, that came in with depression? You had a 10-year-old, a 12-year-old diagnosed with major depression. What would your first line be? I would hope that we have this on a slide here, because your first line in a child, and that is a child, is fluoxetine. Let's see if I put it on the slide. I'm not sure that I did, and I did not, it looks like. Okay. Nope. No, didn't. Okay. So you have a kiddo who comes into your peds office and they've been diagnosed, so fluoxetine is a drug of choice for kids as young as 10 years old. That's absolutely fine. So no problem with that one. Oh, I did put it on. Fluoxetine has short half-life, or a long half-life rather, 1 to 3 days. And first metabolite in 4 to 16 days. First line in children, okay? Because it does have that long half-life. Metabolizes in the liver. Okay. SSRIs, some more of these. You always want to tell your patients what? They think they're going to feel better instantly? No, they're not. Take up to 2 to 6 weeks for maximum effects. I always tell people they're probably not going to feel much till 4 weeks. I figure that's pretty safe. But for testing, 2 to 6 weeks for maximum effects. And you always just give them 1 month prescription when you're monitoring them. When you first start somebody on that, you can always, I usually give somebody a 3 month after that though. Okay, so now we have SNRIs, and that's your Cymbaltas and your Effexors. These are more for major depressive disorders, neuropathy, pain, fibromyalgia, not used in kids ever. I like to use this with the elders, mostly because it's 60 milligrams. It's got a great pain response for the elders as well as major depression. I've had a lot of good luck with this one. A lot of times I'll take them off of, a lot of older people end up on Celexa, which Celexa reacts with a ton of medications, where Lexapro doesn't. But Lexapro I like to use for anxiety, but actually I've been using a ton of Cymbalta in the elders. I start them at 30 milligrams and then I take them to 60 in a week or so, and see, because it really does help with the pain. Let's see. So if you have somebody who's got complaints of fatigue and sleeping all the time and lack of motivation, out of all of the antidepressants like Prozac, Paxil, Elavil, well, Elavil's an absolute out for me. I would definitely pick Cymbalta over all of those. You might want to really listen to what I just said, that you would pick Cymbalta over Prozac, Paxil, and Elavil. And just here's the side effects of the SNRIs. Some of the things that they can cause. They all cause suicidal ideation. The biggest thing with these two is you use them with major depression, which half of our elders do have major depression, actually. You have to watch the electrolytes with the older people also. And then you have your antipsychotics. Haldol I've seen quite a bit recently, and just in a nursing home setting, and I think it's been more just to kind of keep problematic patients to sleep at night. They tend to all sundown at night, and I know that's a huge problem. I usually try to get rid of it when I have somebody come in, once I know the patient and why they're on it. Let's see. If you do have somebody on Haldol, you need to make sure that you are doing the AIMS scale for them, or for the EPS symptoms also. That causes a huge problem, and that's one way to know if you're getting into problems with the Haldol. Also, if you have all these people that have EPS symptoms. Here we also have Zyprexa also, and it's an atypical antipsychotic. If you have somebody on Zyprexa, all you need to know is you need to monitor for their weight gain. And more antipsychotic, this is just some of the other things that can go on. Big thing is you want to watch for those side effects with Parkinson's, prolactin levels, and make sure that see if they're on any anticholinergic medications. You want to watch for those abnormal movements. And your atypical psychotics, one is Risperdal. Okay, and same deal, you're going to watch for bradykinesia, all these other things, agitation, same as any of the other antipsychotics. Yeah, okay, let's see, almost done. Levodopa, carbidopa, Sinemet. These are for Parkinson's disease. You can also give Cogentin in conjunction to reduce the tardive dyskinesia, and you'll often see that where they're on Cogentin and Sinemet. Okay. Okay, so anti-anxieties and hypnotics. You have Ativan, you've got Xanax. You probably prescribe more Xanax than you care to. If you have somebody who comes in and they're really known for having a whole lot of anxiety, the best thing that you can do for them probably is put them on something long-term. So right now for the testing, the serotonin anti-anxietic would be buspirone. It's best for anxiety and depression together. So it's Buspar. It's combined with an SSRI. So that one is best for somebody who comes in with anxiety and depression. So if somebody told you, what would you give? Would you give Cymbalta, Prozac, or Cirex? You're going to say, no, I'm going to give Buspar. That would be the best one to give in that situation where somebody is depressed and has anxiety. Okay. Okay, so let's see. Resveratrol, it should not be used more than 3 times a week unless for 3 months. We all know we have seen people on Resveratrol for a really, really long time. So I'm not quite sure how we all get away with that, but we do. Okay, so alprazolam, Xanax, it's highly addictive and it is great in dependency, right? It's one of the drugs you'll probably give more than almost anything you give. You have to be really careful with it. People definitely, out of all the benzos, this is the most addictive. So it's more addictive than Cirex, Klonopin, and Librium. So just remember that it's one of the most addictive. Let's see. And Resveratrol, when you're giving it for insomnia, once again, should not be taken more than 3 times a week or for 3 months. Temazepam I prescribe constantly, which is Resveratrol. It gets prescribed for patients constantly. And then just a sidebar, not on an exam, might be on your boards though, is about Ambien. Starting March 1st, supposedly every patient you prescribe Ambien for has to have a sleep study on their chart, especially if they are COPD, to make sure that you're not knocking somebody out so much that they're not going to breathe. The other thing is you never give a woman more than 5 milligrams of Ambien. The men can still take 10. I've had somebody fall recently, a man that was in the nursing home on 10. It's just not really a great drug. And as far as Lunesta goes, nobody usually prescribes that. It's too pricey. But Ambien, just be careful with the Ambien use. If you don't have to prescribe it for a woman at all, that's your best bet. And I think Mood stabilizers, lithium, not used much anymore, but valproic acid is definitely used, Depakote, Depakine, for bipolar disorder, and it works pretty well. And opioids. This must be somewhere else, so let me see where it is. I think we're probably going to revisit opioids in another section, but morphine is used for moderate to severe pain. Oxycodone, Percocet is a combo product. Tylenol with codeine, Vicodin, all of those, and also Norco. So here's the thing now, this is in fact in March 1st, Vicodin comes in 500, Percocet the same way. Then you have your Norco that was coming, 7.5, 650, all different ways. As of March 1st, you can no longer give the combo drugs with more than 325 milligrams of acetaminophen in them per tab. So there's going to be some big changes. I don't know what you do with the Vicodin. I guess you can probably scale it down to 300s. I'm not sure how they come, but usually, yeah, it is 5 300s, I guess. But watch the Tylenol. Don't prescribe those drugs because they're not going to fill them. Pharmacies are told not to fill them after March 1st. That's not on your test. That's not on the boards. It's just an FYI. So when you're giving drugs for pain, you're going to give them in the following order. You're going to give non-opiate and increase the dose of a non-opiate and then an opiate. Okay, so you're giving Tylenol or you're giving ibuprofen. Now you're going to increase that, and now you're going to go to an opiate. So opiates, they bind to opiate receptors in the CNS. So you need to know the pharmacodynamics of how they work. Remember, pharmacodynamics never change. Pharmacokinetics vary. Pharmacodynamics is how the drug is made to work, what's in the drug and how the drug does work. Pharmacokinetics is what it does to your body, what your body does with it, rather. Okay, so now we have your stimulants, your Ritalins, and your Strateras and your Adderall. These are other things that it's probably not the greatest to be prescribing in primary care. I do prescribe a lot of Adderall. That's because of what was going on in my practice. You have to bring the patients back monthly. They have to have a hard script. Non-amphetamines or Stratera. Stratera is really pretty expensive, so most people don't want to take it. Ritalin, the insurance companies are starting to balk pretty much at the Ritalin and the Adderall again for adults. So you'll have to kind of weigh the odds with what you prescribe for them. And I think that's it for chapter 15, and then once again there'll be more to come.